So what we're going to do is move forward with our wonderful panelists who have joined us. We also need to kind of start off with the whole concept of what is a fall? Why do we care about falls? Why are we investing this lovely afternoon at the end of a long day talking about falls? And, there's all kinds of definitions that people use. What we know is that especially older people will often negate the number of falls they've had. Oh, I didn't fall, maybe I tripped, or I just kind of stumbled, but it wasn't a fall. So our technical definition for our purposes for a fall is something very technical, but it basically has kind of three main components. One is it's unexpected and uncontrolled. Regardless of what people say, other than maybe stunt people, there's no such thing as a controlled fall. That's what makes it a fall. And it's something that you aren't expecting to do. The second part is that you end up on a lower plane. In other words, if we're standing, we fall down. Nobody on the planet Earth, at least, can fall up. That's not considered a fall. Gravity takes over. And so a fall is moving from a higher plane to a lower plane. Now, that doesn't mean that you have to go from standing to the ground or to the floor. You could fall into a chair and make it look like, one of those very elegant, I meant to do that kind of things. But it still is a fall if it's uncontrolled, if it happens quickly, if it moves you from a higher to a lower plane. So you can fall into a wall. If I'm standing up and walking and I end up falling against a wall, maybe not quite as much of a drop in my height as I had going to the floor, but it still is moving to that lower plane. So that's what we want to keep in mind and also remind people of. And that falling isn't something people should be ashamed of. It's something that we just need to be aware of so that we can find ways to mitigate or reduce those falls. So why are we doing all of this? Because falls are the number one cause of accidental injury and death in people over 65. And it's also one of the top 5, I believe, for people of all other age groups. So falls are a big deal. And most importantly, we like to say all falls are preventable. And that's one of the reasons we're here, to learn what they are, how they impact people, and as a practitioner, how we can help our patients or our clients understand those factors and, again, reduce their fall risk. So with that, I am going to get us started off with Dr. Rodney Bates from the Idaho College of Osteopathic Medicine. He has years and years of experience as an internist and a hospitalist. And as I said, is currently working with faculty at ICOM. And I'm going to let Dr. Bates take over.
Thank you, Erin. My name is Dr. Rodney Bates. I'm primary care chair at ICOM and also assistant faculty in internal medicine. So ending up in the ditch, what is this referring to? This is actually a personal story of my grandfather who, shortly after receiving a new knee replacement, had decided, hey, I'm a strong farmer. I've done this many years. I'm just going to go out and try to jump the ditch. Well, he miscalculated and fell in the ditch, ruined his new knee, and had to get that repaired again. And that was a point of starting to realize that he couldn't actually do what he used to be able to do, and realizing that, hey, I'm going to continue to injure myself. So next slide, we're going to discuss in terms of falls. There we go. So what are the physical impact of falls, and really what do we worry about from a physical standpoint? So basically what happens to our bodies. Next. So the first obvious one would be any issues with the major organ in our body, our skin, our dermatologic covering, and what happens when we scrape ourselves, bruise ourselves, so we can have avulsions, lacerations, especially these older individuals who have more brittle or fragile skin. And so avulsions, lacerations, significant bruising is so easy to get. My own stepfather suffered from this as well, and just would slough the skin off the top of his hands if he fell to the ground. Bed sores, obviously, if you're falling and you can't get up as significantly as previous, then you're going to develop pressure ulcerations. And these are the more obvious ones, bone fractures. But if you think about the skin and the protective effects of it, risk of infection is always going to be an issue. Next slide. So this next slide is dealing with obvious concerns that we all think about in the medical profession, and that's bony fractures. The most feared and significant one being the hip fracture, which carries a significant mortality risk, up to 50% of mortality within the first 5 years post hip fracture. And so that's always the one that we're concerned with. Obviously, pelvic fractures would sit in that same category of high risk fractures. And these are ones that we see quite often in the elderly and really should be avoided at all costs. Obviously, things like osteoporosis and other health needs that can be prevented, hopefully will help with these significantly, but also just reducing the risk of falls. Spine injuries and fractures, compression fractures to the spine, obviously a big risk. Wrist, ankle, trying to outstretch and catch themselves, which is also a very slowed response in the elderly. And then obviously ribs, clavicles, these can be very painful and debilitating and lead to other things such as pneumonia, where a patient just can't breathe deeply. So the other obvious ones, head injuries. So what happens if a patient is taking anticoagulants? Well, they can get an easy brain bleed just from sheer force of the venous vessels around the brain and in the brain lining. So basically leading to intracranial bleeds, concussions, fractures of the skull, and other common outcomes, obviously, ones that we may not think about as far as debilitating us would be pain, obviously leading to decreased motion and function, where you really lose more of that function, and also increased risk of future falls. So if we look at the overall increase in fall death rates in the United States, it is very significant. This is a population health issue. And if you look at what the CDC has estimated based on falls, 7 fall deaths every hour by 2030, we're going to have a significant increase. And it's increasing year after year, as you can see from 2007 to 2016, quite a significant increase in death rates and propensity for these falls in these adults. And as the population is aging, we know that a significant proportion of the population is aged. So if we think about elderly status, greater than 65, and I don't mean to offend anyone by that categorization, that just is what it is. I'm approaching it every year. We all are, right? Post-discharge from the hospital. So if you're considering, hey, these falls, they're putting these patients at risk. What happens post-discharge? What's the data show? What's the general outcomes? And this is based on a little older data, but something helpful to consider. Half of these patients upon discharge require some form of placement. That may be in a nursing facility, in a rehab facility, with home health potentially, but only 1 in 3 may go home without any assistance. Only 6% with some form of assistance, and 5% needed a full rehab facility prior to moving on to the next level of care. Half of these eventually get readmitted just due to that increased risk of future falls and future comorbid conditions that may be affected. 1 year after injury, only 1 in 4 of those discharged. Only 1 in 4 were discharged from other facilities. 1 in 3 really have been found to have passed away. So the significant mortality benefit, like we said, in this case, 30%, carry that out to 5 years, up to 50%. 3 times greater risk of death for those required to be admitted to a facility of some kind.
Well, thank you very much, Dr. Bates. It's always that last slide that kind of, I think, hits it home, where you go, okay, this isn't just a skinned knee. it's significant injuries and injuries that start us into kind of that cycle of where sometimes people, especially when they are older, don't leave facilities or don't survive much longer after that. So sorry about it, Dr. Kinahan, but on that positive note, thank you, Dr. Bates. We're gonna let you take over, and Dr. Kinahan, who is new to our panel this year. We're very glad to welcome you, and thank you so much for investing the time to be here. She is going to tell us a little bit about the fall cycle, the fear of falling, and then some things about how medications can impact our fall risk. So Dr. Kinahan, take it away.
All right, thank you so much for having me. So as Erin was saying, this is my first year doing this presentation. I'm an internist and a geriatrician at St. Alphonsus, where I started the fall prevention clinic. And I've had a special interest in falls since my intern year. So I'm always happy to talk about falls. So the first thing to say, I think having all learned about the consequences of falls is how important fear of falling is as a consequence for patients. It's defined as the fear of standing, walking, or moving because one might fall. About a third of women over the age of 70 are afraid of falling, and half of those will remain fearful even after 3 years, regardless of rehab measures and steps that are taken. This is huge for impact on patients. Patients report increased depression, less mobility and less balance. As we know with older adults, depression and cognition kind of go hand in hand. So patients who are experiencing these mood effects often will report subjective cognitive symptoms as well. And then patients who live alone are much more likely to express a fear of falling. And anecdotally, my impression is that having more support at home allows patients to feel a little bit more confident, particularly when their balance is being challenged. One of the concepts that I talk about with my patients is self-efficacy, and specifically self-efficacy related to falls. And that's how confident do patients feel that they can perform a task without falling. And in our clinic, we actually have a scale that we offer to patients that gives them an option of, I'd feel pretty confident doing this, I'd feel a little worried, I'd be very concerned, or like, I just don't do that activity because I worry about falling. And it includes things to kind of tease out if patients are afraid of falling outside of the home, inside of the home, doing certain activities, and it helps kind of gauge where they are as far as their self-efficacy. And I repeat that questionnaire after they've done some physical therapy, and I like to see their score going down, or the flip way to think of that is they are having increased self-efficacy, self-confidence, which is associated with higher or better outcomes. The fall cycle refers to this kind of loop that patients can get in where they have their initial fall, they worry about falling, so they do less activity, they challenge their balance less. As a result, they become deconditioned, and now they're at even more risk of falling. Patients with low self-efficacy who have kind of self-titrated their activity downward are more likely to have more complications, require placement, require more assistance in their home, use of assistive devices, for example, and as we kind of talked about before, certainly increased risk of death. As additionally, there's this concept of social well-being associated with fear of falling. I liken it to a formally diagnosed agoraphobia, for example. Patients will frequently not feel comfortable leaving their home, not feel comfortable engaging in activities that they used to enjoy. And as a result, they do suffer quite a bit. So getting an opportunity to reduce falls in your patients and increase their self-efficacy is very, very important in lots of ways. So there's a few things that we can do kind of depending on your role in the healthcare team. One thing is making sure that everybody is coordinated and prioritizing fall risk. And so it's not just physicians and then going straight to PT, OT, but also having buy-in from people like the pharmacist to make sure their medications are safe, making sure that if the patient is an inpatient particularly, nursing staff are aware of the patient's risk of falling, but encouraging mobility all the same. And then for me, the buy-in from caregivers and family particularly in my clinic, is huge, because having that family support makes such a difference in terms of their ability to get back some function. At every visit, I think we end up asking about when was the last time you fell, so that if the conversation needs to steer towards what are your particular risk factors, I'm able to kind of counsel patients in that way. Additionally, appropriate treatment. So I think there's kind of a tendency to say, oh, any exercise is great. As long as you're exercising, I don't mind what you're doing. Really, though, for patients who are at risk of falling, it's balance-specific training. And so that's things like Tai Chi. The community has classes called Fit and Fall Proof, which are fantastic. Low-intensity exercise is also wonderful for increasing self-efficacy, but sometimes that can be kind of a harder sell for patients if they're worried about falling. And if fear of falling is interfering with their ability to live their lives and causing depression, it is completely reasonable if the patient is willing to, for them to be referred for cognitive behavioral therapy, so that we can look at how are those thoughts and emotions affecting their behaviors and what interventions we can make.
So I think that so far, we're starting to see kind of some things that all tie together, like Dr. Bates talked about as well, that falls cycle diagram, I think, really conceptualizes the whole thing that most of us have probably seen. Somebody falls, then they're afraid to get up and be active, and then other health factors deteriorate, and we get into that negative downward spiral. And as Dr. Kinahan mentioned, part of that we have also seen greatly magnified for the last 18 months or so, when people who are living alone are afraid of falling, and nobody will be able to come and be with me or to help me. So it's just kind of magnified some of those issues. Well, hopefully you've had a chance to take a breath, and now you're ready to take us into medications. And what I'll say before Dr. Kinahan gets started is, we all know we can take semesters, years worth of training on pharmacology. So we're just going to focus really on kind of some of the high points that impact falls. So take it away.
Sure. So I love approaching falls with a view towards deprescribing, which is kind of rationalizing the patient's medications. The first thing I'll say is that with any medication, whether it's over-the-counter prescription or it's just a supplement, especially with older adults who have altered pharmacokinetics and different rates of absorption and volumes of distribution, it's very important that you're balancing out the fact that the patient has some diagnosis that requires medication and treatment versus the risk of side effects. And today we're particularly talking about falls, but for me as a geriatrician, I also worry a lot about cognitive effects. In our clinic, I want to know everything the patient is taking, not just what the EMR says. We sometimes ask them to actually just bring in a box of all of their medications, so that we know everything they're swallowing. When it comes to prescribing for older adults, I think about inappropriate prescribing as multiple kind of sides to the same problem. Inappropriate prescribing is defined as when the risk of a medication outweighs the benefits. Generally, what we see with older adults is overprescribing medication. Patients are on too much medication, they've been on it for too long. A classic example is a patient who had an MI 20 years ago who's still on a beta blocker, for example, when the evidence says really probably only need it for 3 years. Or what's just called polypharmacy, and I'll talk more about polypharmacy later. There's also misprescribing, which is you got the diagnosis right, but the choice of medication or the amount or duration was incorrect. And then there's underprescribing, which I do see quite a lot with the geriatric population. And that's when a medication is indicated. There's no clear contraindication, but for whatever reason, cognitive biases that we all have, the medication has not been prescribed and would have been appropriate. So the definition of polypharmacy is a patient who takes greater than 5 medications. What we worry about particularly is unnecessary medications. If you've ever had a patient with congestive heart failure, you can get up to 5 medications in no time. However, the total number of medications is the predictor for both inappropriate prescribing and potential for adverse drug events. Over half of Medicare patients are on more than 5 medications. And as I mentioned, it is important to consider when prescribing for older adults, not just is this medication appropriate, are there too many, but the ways that our metabolism for drugs changes as we get older. The reason I'm harping on this so much is that the more medications you're on, the more likely the patient is to experience either an adverse drug event from a single drug or an interaction between drugs. Additionally, once people are on greater than 6 medications, we see a huge loss of compliance, and that's particularly when they are on more than once daily dosing. And I worry about that because if they're on more than 6 meds, I kind of worry that they're not actually taking medications correctly. And some medications, as we know, can be dangerous with stops and starts, like anticoagulants. And then, of course, we have to come back to falls. Patients who are on multiple medications greater than 6 are at increased risk of falling, as well as syncope and cognitive impairment. So as I said, greater than 6 medications daily increases risk of falling. Is that the medications itself? Is it because people who need more medications are more frail? Probably both. There are specific drug classes that I am always looking out for patients who are falling or who are at risk for falling. And those are benzodiazepines, non-benzo sedatives, antidepressants, antipsychotics, maybe a little bit less so because generally the benefits will outweigh the risk in those cases. And then cardiac and hypoglycemic medications, same thing. Generally, if they're on it, you hope that it's needed. And then a big risk area for patients is if they've had their medication doses adjusted recently. And that's not just their PCP doubled their hydrochlorothiazide. That can also be discharging from the hospital, being admitted to the hospital, and medication reconciliations not going perfectly. So antihypertensives, we worry about with older adults because of the risk of orthostatic hypotension, which is when your blood pressure drops when you go from a seated to a standing position. If you've ever stood up too quickly and felt a little lightheaded, you probably had a postural drop in your hypertension, in your blood pressure, sorry. Additionally, patients who are on diuretics like thiazides or loop diuretics are prone to hydration or dehydration. And as we get older, our thirst drive becomes diminished. So it can be hard for patients to keep up with their fluid needs when they're on thiazides. And then again, going after thiazides in a big way. Thiazides are notorious for causing hyponatremia, and hyponatremia is associated with all kinds of poor outcomes, but particularly falls and cognitive impairment. I think I've beat diuretics enough, but the one that I think people kind of forget about is tamsulosin, which is commonly prescribed for BPH or for patients with kidney stones. Usually patients take it at bedtime. And so the time I worry about their postural drop is going to be first thing in the morning. So I counsel patients to get up slowly when they're getting up in the morning if they took their tamsulosin the night before. Medications for diabetes are at risk for causing hypoglycemia, particularly if the dose is incorrect or if the patient's oral intake has changed. So insulin, glitazones, and sulfonylureas are kind of the main classes we worry about. I generally prefer metformin. It seems to be better tolerated, and important to remember that patients who are older, your target A1C is only 8%. So if you're pushing someone down to the 6%, you're increasing their risk of falls. This is the area that I get the most worried about. Patients who are taking antipsychotics, who are already impulsive and lacking some judgment, if you then add on an antipsychotic, you do increase their risk of falling. I hope none of us are prescribing zolpidem at this point, given everything we know about it. But once in a while, I'll see a patient who's taking one of these so-called Z drugs for sleep. Huge risk of falling, particularly if they get up in the middle of the night to go to the restroom. And benzodiazepines have for a long time been associated with falls, particularly if they're being used chronically. I think there's not really a safe benzo for older adults, so I stay away from them completely. And then can't forget some of these non-prescribed substances that some of our patients, particularly the ones living closer to the Oregon border, like marijuana and of course alcohol, both increase your risk of falling, particularly if combined with any of these other medications. Continuing on, anti-epileptic drugs that are used for pain, particularly gabapentin, carbamazepine, tend to increase risk of falling. They increase dizziness, especially when they're first being started or when the dose is increased. Antidepressants, I worry about a little bit less. If someone has been tolerating them pretty well to date, it's not the first medication I go after, but fluoxetine and sertraline do have a higher, what's called anticholinergic burden compared to other SSRIs. Amitriptyline and nortriptyline are tricyclic antidepressants, a huge association with falls. And I stay away from them even for peripheral neuropathy. Trazodone, we all kind of hoped was safer than the Z drugs, and it's really not as far as fall risk, particularly those nighttime falls or first thing in the morning falls when people have taken trazodone the night before. And then almost all opioids, including tramadol, which again, I think we all kind of hoped was going to be safer, are associated with falling in older adults. So anticholinergic medications, this is a huge drug class, and I don't want to kind of go into too much detail, particularly because I'm not a pharmacist. But the things we worry about besides falls are cognitive impairment, urinary retention, and the cognitive impairment effects can be pretty subtle. And I've seen patients who were taking diphenhydramine, which is Benadryl, kind of chronically, and they're fine. And then one day they're just not. They're more confused, they're falling. Common medications that are anticholinergic effects are anything that's nighttime or PM. Usually the sleeping component of it is diphenhydramine. Also Unisom, which is doxylamine, and hydroxyzine, of course. Oxybutynin is a huge anticholinergic effect. That one is for overactive bladder. It works really well for patients, but I try to get them off it onto something else when I can. And so patients who are having pain, the problem is their pain is real, but their medications may be putting them at increased risk for falling. So ideally, getting help that they need, going to a chronic pain specialist, getting other non-pharmacologic options for pain is kind of the way to mitigate that risk as much as possible. At least once a year, go over medications with your patients. Stop anything that's unneeded or unnecessary. Wherever you have a chance, it's good to switch to a safer alternative. Aim for the lowest effective dose, particularly for pain medications. If they're getting by with hydrocodone twice a day instead of 4 times a day, great, stick with that. I always make sure that I'm communicating with, for example, cardiology. If someone is taking 6 cardiology meds, I call a cardiologist and say, hey, do you think they really need all 6 of these? And I get input from our pharmacist. If you're ever not sure if a medication is potentially dangerous, the American Geriatric Society publishes a list called the Beers List, and you can look up the drug in question, look at what the side effects and risks are, and it often will recommend something that's generally safer as well.
All right, well, that was fantastic. And I know my brain's zipping around for all the different things that you said. Some of them are, yeah, that's me, or just, wow. But we will, again, have copies of those slides for you in a recording so you can listen to all of that helpful, useful information and tips after the seminar is over as well. So now we would like to move on to Dr. Seeger. She is our expert on nutrition and hydration and all of the wonderful things that she will explain that go into kind of falling or preventing falls, kind of from the physical and physiological standpoint. So Dr. Seeger, you are on.
Thank you, Erin. I appreciate it. All right, so we do know that falls are multifactorial, and a couple of the reasons that could be are nutrition and dehydration. So we all know that it's important to keep our bodies fueled, but it is important to take the right fuel. As we age, we lose muscle mass and we lose some strength. We end up with some nervous impairments, and that's basically we react slower as we get older. But sometimes as we get older, we become malnourished, and either we're undernourished or malnourished. And whether or not that is due to a lack of funds to buy food when you have to pay for medication, or lack of transport to the local grocery store, or dentures can cause a problem because you can't eat your food. Whether it's due to sight, vision, so you can't actually see what you're doing in the kitchen, or whether it's due to safety, so you can't recognize if the food has gone bad or not. But we do know that when you're undernourished and malnourished, you're more likely to fall, and this obviously relates to a negative impact on function. In conjunction with nutrition is hydration. We do know that hydration is vitally important for all people. Most Americans, most in the United States, are dehydrated. That's across the board, irregardless of your age. But we know that dehydration leads to low blood pressure because you don't have enough fluid in your bloods, weakness and dizziness, confusion. All of those things can occur because of dehydration. We have difficulty as we get older recognizing that we're dehydrated. The osmoreceptors in the hypothalamus get less sensitive to changes in the osmolality in your blood, and therefore you don't recognize that you have low water in your system. And so by the time you do recognize that you are already moderately to severely dehydrated, in conjunction with that, you might have musculoskeletal and nervous problems, so it makes it difficult to get to the bathroom on time. So you're not drinking as much because you don't want to have incontinence. So signs to identify dehydration: we got fatigue, confusion, lightheadedness. You can even take and pinch the skin on the back of your hand, and if it stays raised, you are dehydrated. It should return to its prior condition before you pinched it. So dark color of the urine, if your urine is getting too yellow, you're dehydrated. And this is why we as healthcare professionals ask those questions. What color is your urine? Because it can give us a lot of information about their health status. So we need to consistently remind people to drink. And if people are incontinent, if they drink more, they'll be less incontinent. It seems backwards, it seems reverse logic, but it's actually true. If you drink more, your urine is less concentrated. It's more concentrated when it's dark yellow, so it's less concentrated. And high concentration urine actually irritates the bladder, causing incontinence. So if you can decrease the concentration of your urine, you won't have to go to the bathroom as much. Little things like that can make a big difference. Alcohol. We do know that alcohol impairs mental abilities, but alcohol also helps dehydrate you. Alcohol messes with your medications. So there are many people in the world who get their water content through alcohol, and you should not be doing that. They'll get their nutritional, their calories through alcohol, and it doesn't help your body at all. It messes with your medication. It causes digestive problems. It decreases your appetite overall. So we do need to have these difficult conversations with our patient about how much alcohol are they drinking. And most people underreport the amount of alcohol they're drinking. And it is their entire nutritional component. So we need to encourage our patients to eat a healthy diet, help them find the resources so they can get a healthier food. If they can't afford it, what can we do to help them? If they are concerned about incontinence, please refer them to a pelvic health specialist physical therapist. We as PTs can actually help resolve incontinence without the use of medication. We can also help people women especially resolve up to level 2 prolapses without surgery or any other types of interventions. So pelvic health PT can actually help people quite a bit when it comes to those types of issues. Educate about dehydration and why it's so important, and how to take one of those Nalgene or water bottles with you where you can go. Have a frank conversation with your patients about how medications impact your diet, what medications you should eat with, should not eat, what food you should eat, what food you not should eat, how you should drink fluid, and how alcohol impairs your hydration.
Well, that helps us get started with a whirlwind of tips and things that we kind of say we should have already known that, but probably not in those terms. But now we're going to let you continue on, not only with what we intake, but what actually happens with our muscles and nerves as we age or have issues with potential falling concerns.
As Erin said at the very beginning of this presentation, that the vast, vast, vast majority of falls are preventable. Occasionally you just have one that you can't prevent, but that's rare. So when we're looking at fall prevention, we're looking not only at nutrition, hydration, we're looking at strength, balance, flexibility. Next. So the first thing we look at, especially from my field as physical therapy, is power. And we do know that the number of muscle fibers don't change as we age, but how we use them changes. We know that our fat to muscle ratio changes as we age. And that starts in your third decade, so your 20s. Those changes start happening very young. How well your nerves talk to your muscles starts changing relatively young. Also, as we do age, our reaction time slows, so our ability to recover from a balance slows. We have different types of sarcopenia. We have what's called non-sarcopenia, pre-sarcopenia, stage 1 and stage 2. Everything up to stage 2 is reversible. We can reverse sarcopenia up to stage 2. At stage 2, it becomes pathological, and you have a significant increased risk of falls if you have stage 2 sarcopenia, which is a significant loss of muscle mass, of muscle strength. So by the numbers, this was a study, you see the reference at the bottom of the page. They looked at quite a few older adults, and they found in that population, pre-sarcopenia was about 6.7%, stage 1 was about 13.8%, stage 2 was 12.8% of that population had those stages of sarcopenia. But if you look at the percentage of falls underneath of that population, how many of them had fallen? So if you look at the severe stage 2, 72% of those who had stage 2 sarcopenia had fallen already. And so the odds ratio of you falling, if you have stage 2, the hazard ratio was, I think, 4 point something, which is considerable, 4 times the risk of falling if you have severe sarcopenia. So if you start losing muscle mass as you get older, we need to get you in an activity program, whether it be exercise or activity, to reverse it before it becomes pathological. So one of the things that we worry about more as we get older is not necessarily strength, but power. So how fast can you move with strength? It takes more strength to move slowly. So if you're trying to get out of a chair, it takes more strength to get it out slower than if you do it quickly. So when you're looking at exercise programs, we want to look at 40 versus 80% of your 1 rep max. That's 1 RM, 1 rep max. If you're looking and exercising at 40% of your 1 rep max, that's working endurance. So your muscle endurance. If you're working at 80% of your 1 rep max for your muscles, you're working strengthening. So you're strengthening the muscle. So how do you tell if you're doing 40 or 80% of 1 rep max? It's how many reps you can do before you fatigue. If you do 15 to 25 reps before you fatigue, so you break form or you can't do it again, that's working between 40 and 60% of your 1 rep max. If you do 8 to 12 reps before you break, you're working between 75 and 95% of your 1 rep max. So how many repetitions you do when you do strengthening, when you do your 8 muscle groups a day, is looking at, are you doing it at endurance or are you doing it for strength? Do it however you can, but change the speed of your exercise to work power. There's several very good articles that look at power. And if you do less reps, but faster, it has a very big impact on to decrease your fall risk. So we need to actually look at speed of exercise, speed of activity, speed of doing whatever you're doing. And it makes a big difference in how often you fall. Staying flexible. Flexibility matters. Stay moving, stay stretching. If you stiffen up, you have more difficulty regaining your balance when you lose it. If you aren't flexible, you have more difficulty getting in tight situations, getting in and out of that car, stepping over something. So you need to stay flexible. If you get stiffer, you're more likely to fall. Flexibility and aging. So we do know that as we age, we lose the elastin in our body, which is the stretch fibers of our body. And as we lose them, we have more difficulty taking in a deep breath. We have more difficulty touching our toes, which I can never do anyway. So it doesn't matter for me because I couldn't do it when I was a kid, so I can't do it now. But we do know that naturally as we age, we lose elastin, but we can offset the stiffness by stretching programs, by continuing to actually reach for things rather than tightening up and not doing as much. Staying balanced, it's a combination. It's not only your balance systems in your inner ear, your eyes, your skin, and your joints, but it's also how flexible you are, how much power you can produce, how strong you are. Your confidence, your fear of falling matters. If you are so afraid of falling that you don't do anything, you're more likely to fall. So how well your nerves talk to your brain, all of these things matter. And so continue to challenge your balance. The only way to keep your balance good is to continue to challenge your balance. So we do know that we need to challenge things, and many of these declines are preventable. what we think of normal aging with stiffening and losing our strength is actually more pathological than true aging. We can prevent a lot of loss just by keeping moving. So we have changes. We don't move because of pain or because of hearing or vision problems or lack of independence with transportation or difficulty doing other things. And so we end up isolated, which is this negative cycle that we've already talked about. But we need to find ways for our participants or our patients to actually do things in environments that are comfortable for them and do it in a social way. Find a friend to stay active with. If they can find a friend, they're more likely to be active and exercise. I would actually recommend them to be referred to a physical therapist so we can specialize their exercise program to them. But these are general exercises that are good for the vast majority of the population. And as we've already said in this one, here are things. So encourage walking with neighbors, friends. Household chores are considered activity. Gardening is considered activity. Walking to go get the mail is activity. Attending Silver Sneakers or Fit and Fall Proof, going to the gym or senior center, but moving is the key. Anything we can do to get our people to move, the better. The worst thing you can do is sit down and just sit.
Thank you so much. I love this quote, and we'll let the audience read it as we move on. But I am going to actually do this. We do want to talk a little bit about falls and chronic conditions. There are all of these factors that come together. It's usually not just one thing. It's nutrition and hydration and medication and physical strength and stamina and power and all of these other things that go into whether we are going to fall and how we are going to be able to respond to that fall. Many of our chronic conditions impact our systems in ways that make this challenging. For example, a diabetic, very commonly neuropathy, so not a lot of good feeling in your feet, can make you misstep and stumble or fall. And of course, diabetes is one of the #1 causes of blindness in the world. So diabetics, along with the medications, go into that. Vision loss in itself is just, like Dr. Seeger mentioned, that's one way that we keep balance. So when you lose your vision and you don't have visual landmarks to work off of, we can become unbalanced and fall. Chronic pain, this one's come up a lot too. It impacts how we feel. It makes us feel like we hurt and we don't want to get up and move, but moving is the best thing we can do for pain. It may mean that we're on one or more pain medications that can negatively impact us. And a lot of those medications impact our thirst and hunger. So chronic pain is really one of those things that is huge in our country right now and really can be addressed in many ways. And I am going to do the little bit of a plug here, which is that part of what Commission on Aging provides are self-management workshops that are completely free for people to take. They can be done either virtually or in person. And two of the most popular ones that we have are chronic pain and diabetes self-management. But we also just started a continence program called Mind Over Matter for some of those urinary and bowel issues that we referred to earlier as well. So it doesn't take a lot of money. It can be done in conjunction with other healthcare people, but addressing things like chronic pain and good diabetes control are really important. No system is an island. That's basically what we were just saying. I happen to be a diabetic who also has multiple sclerosis. So I got all kinds of things going on, all kinds of meds going on. So I'm just sitting here nodding yes, yes, yes to everything that all of our experts have been saying as we go along. But the point is that many chronic conditions impact other systems in all kinds of ways. And that's that communication and awareness. And we need to help our patients be aware of the potential impacts on their fall risk so that they can prevent the falls rather than going, oh, I didn't know that that medication or that condition could do that. And this is going to take us into our last very short but important section. It's important because the title of this seminar was Falls Assessment as a Matter of Practice. And we've talked about all of the concepts and all of the interrelated factors into falls. But what we really want everybody to take away from this presentation is how you can then become part of the falls prevention team. Whether you're a primary care physician, whether you are working with somebody in a nursing capacity, OT, PT type of facility, CNAs, people that work with people in their homes who may not be getting a lot of other types of care. Everybody that's involved needs to be aware of falls and how to assess the fall risk. So we're going to let Dr. Bates finish us up with a couple of very quick ideas on how you can include falls assessment in your practice.
Yes, thank you, Erin. And has been mentioned already, all of these risks. What can we do about it? What types of preventative measures can we take as primary care providers, as well as potentially family members as well, and assess for that strength or that power and that ability to avoid a fall. There are some things that we can look at to try to get some form of objective data, as well as hearing from family members saying, hey, mom or dad is getting really, really shaky and they're going to fall. We want to take that seriously as well. But simply asking about those kinds of difficulties for a patient, from a family member, whoever may give you the best data available is the most important. So again, evaluating on a yearly basis for fall risk in these elderly patients. Evaluating strength, balance, and gait are very important. And there are some tests that we can perform, such as the timed get up and go test or tug. Timed up and go is the same. This checks gait over a period of about 10 seconds. You have a patient, and it's a simple, quick procedure and evaluation you can do in the office for primary care providers like myself. Get up from a chair, walk across the room, come back and sit down, and within 10 seconds, if they're able to do that well, or time them for 10 seconds and see how far they can go, hopefully they're doing that quick and easy. There are some other formal fall risk tools that are a little bit more involved. You'll see the time up and go test there in the middle. But these are some other scales and evaluation tools that can be used. I'm sure Dr. Canali has used these significantly, but these are just some that are listed that can be looked up. I won't go through these individually, but yeah, just know that they're out there. There are tools that we can use, and we'll go ahead and take some panelist questions, I'm sure, Erin.
That is where we are. And before we do that, I'm going to do a quick little close, but if our panelists are able to stay for a couple of minutes, if not, that's okay too, or our participants need to leave, I do want to thank everybody for being part of our inaugural, very first seminar that is specifically designed for healthcare pros and those who are soon to be healthcare pros to get really this very important topic. And while it's extremely complicated and complex, it also is very easy. Ask the question, have you fallen in the last 12 months? Then you can do other things from there if you need to. It doesn't take much time. It doesn't take any extra effort and can be done, like Dr. Bates just said, in an office visit. So I'd like to thank everybody again. If anybody has questions, please feel free to put your questions in the chat. And we have Amanda, who has been lurking behind the scenes. Actually, she hasn't been lurking, she's been there behind the scenes, and she is waiting to take any Q&A questions that we may have from the chat. Amanda, have we had any questions yet?
Erin, this is Mike. I just have a comment, if that's okay.
Yes.
All three presenters today were really great. I'm not a provider for patients, but I sustained a fall this week myself. I'm in my 40s. And all three of them helped me personally get some ideas of possibly what was wrong or what the problem was, and some things that I need to do. So I just want to say thank you because it was very helpful to me personally, and I'll share that with the people we work with as well.
Excellent. That's good. That's exactly what we want to hear. If every person can take away just even one thing that they learned or that is going to be helpful to them, it's fantastic.
So I think it's called orthostatic hypotension. I'm talking to my doctor about that when I get back out of Boise.
Yep. Any other questions we got, Amanda?
I do have a question. Dr. Kinahan, you mentioned 6 plus meds, including OTC and supplements. What older folks are not on supplements, and OTCs? I think it was a comment.
Yeah, I think that's a great question. The answer is almost everyone is on at least one supplement, it feels like. And, you know, OTCs, they're not all created equal, right? There's a difference between taking Advil once in a while because your shoulder hurts compared to taking Benadryl every single night as far as risk. I think I saw one gentleman last week who was taking 2 medications. One was his statin and one was melatonin, and that was it. But it's pretty rare. You're right.
Thank you.
And this is Erin, and I'll just pipe up on that. I used to very proudly say, it was actually 6 years ago, that I'm a type 1 diabetic, but the only thing I'm on is insulin. It's changed a lot. And I'm not sure if it's because I got way past that. What was it you said? The first 3 decades? I'm a little past the 3 decades. But you're right. I think most people these days are on meds. And I think what Dr. Kinahan was also trying to say was, you know, well, put it this way. My husband used to say to me, "You're the only nurse I know that doesn't believe in medication." And I say, no, I believe in medication when it's necessary, but I don't believe in medicating every little thing. So, you know, if I get a headache, that doesn't necessarily mean I have to run out and take a med for it. And I think that was kind of Dr. Kinahan's point, is appropriate prescribing and not over prescribing, and certainly being aware of what's being prescribed with what else, which is part of that team. Did we get any other questions, Amanda?
No other questions.
I may throw one in here, Erin, as well. And I'm sure Dr. Kinahan has heard this same thing from patients that come in and say, well, I've been taking this medication for years. Why would it give me problems now? And I think Dr. Kinahan actually referred to that very well. You know, our pharmacokinetics changes, our volume of distribution changes, and just as we age, there is that differing effect. And sometimes that's hard to communicate with patients. I don't know how you do that, Dr. Kinahan, if you have any wisdom for me on that as well.
Yeah, so that comes up a lot with people who have been taking benzos since like the 80s, right? And so the way I phrase it is that was an appropriate medication for you when you were in your 40s, but your body has changed now. What's nice about falls is people are usually pretty motivated not to fall. And so I anchor it against something that they do want, which is safety, and what they don't want, which is to come off their medication. And if I kind of offer it up as, well, would you like to continue your benzo, or would you like to go move into a nursing home next year? That kind of gets the point across. I don't usually have to go to that extreme, but you know, sometimes you have to.
That makes perfect sense. One of the things as a diabetic I always had to learn was it's always changing, because it's based on everything in the world, stresses, physiology, hormones, you name it. So, you know, insulin changes over your life are something that I use when I'm talking to people about how the need for medications or the dosages can change. Don't forget, we have 2 more seminars coming up for Falls Prevention Awareness Month. The next 2 Wednesdays. Next Wednesday on the 22nd, we are talking about trip hazards at home and how to remove them. And on Wednesday, the 29th, we are talking about simple steps, which will make Dr. Seeger very happy, which are simple movements anybody can do from anywhere to help get that strength, power, flexibility that she was talking about taken care of. So we hope you will join us then. Thank you again, and everybody have a wonderful afternoon or evening, depending on where you're joining us from.